let's give that a minute. So I'm working in the complex menopause clinic in Holles Street. Our clinical lead there is Deirdre Lundy. Deirdre and I have worked together in menopause care for many, many years now. And the women that we meet in Holles Street are commonly coming in with a background of heart disease, previous stroke, challenges with their circulation, clotting disorders or previous blood clots, as well as hormone-sensitive cancers. So we spend all of our working time supporting women with very complex heart health issues. And for that reason, it's very important for us to keep absolutely up to date with what the current advice and guidance and what the evidence is in providing support for women going through menopause who have any illness that affects them from a circulatory disorder, whether they've had a previous heart attack, whether they've had a stroke in the past, whether they've a high family risk of early heart disease and heart attacks, or whether they've had blood clots in their lungs or blood clots in their legs in the past. And we're part of the British Menopause Society and the International Menopause Society. So as a group, we work very hard to pull all of the evidence on that together. And the question I'm going to answer today is it safe to use hormone replacement therapy if you have a diagnosis of heart disease, or you've had a stroke in the past, or SCAD, or any of those conditions? So what we know is that cardiovascular disease has an enormous impact internationally, and it's responsible for 35% of deaths in women around the globe. And that comes from a study from the Lancet that was commissioned to look at cardiovascular disease. What I did was pulled up some of the information from CSO on the figures related to heart disease in parallel to breast cancer, just to demonstrate how important heart disease proportionately is in comparison to breast cancer, which is a condition that we all spend an enormous amount of time worrying about. But if you look at the figures for 2022, 4,629 deaths were recorded for cardiovascular disease in comparison to only 807 for breast cancer. Now that's spread across all ages of women, so those figures in themselves are alarming, but that's the entire nation of Ireland for 2022, from age 18 up to 100. So a very wide range of ages. But what's been recognised now is that, yes?
Sorry to interrupt, Nicola. I might just share them on my end. They're just that they're not loading completely. Okay, that's all right with you.
Yeah, that's no
sorry
problem.
to interrupt you now.
No, you're fine. So do I need to stop my share at this end?
Yes, please, if you don't mind.
Okay. So while Aislinn's doing that, as I was saying, it's been recognised that hypertension, high blood pressure, is considered the most significant modifiable factor for cardiovascular related deaths. And 64% of women under 40 with a heart attack were smokers. So we know that smoking as well is an enormously important aspect of heart health. Women who smoke die 11 years earlier than non-smokers. Typically, women present with cardiovascular disease 10 years later than men. That does not mean that they've developed their heart disease 10 years later than men, but they don't present to doctors looking for help. The challenge with heart health in women is that as women, we're the first people that will presume that whatever symptoms we're having, it's not likely to be our heart because we're a woman. So women are very slow to come forward looking for healthcare if they have symptoms that could be connected to their heart. Women with other diagnoses like diabetes have a higher risk of heart disease. And if we move to the next slide, we know that estrogen as a hormone has been very protective throughout our reproductive lives of our blood vessels, and it provides the benefit that reduces the diagnosis and delays disease progression in comparison to men. And that's what explains the gender difference in the age that these things present at with heart disease and stroke. But when our estrogen levels start to fall during perimenopause, changes already begin to happen in the blood vessel walls, and we're more at risk of cholesterol plaques forming inside our blood vessels. With the changes in estrogen at menopause, there are other aspects of our metabolism that are also undergoing change. So our insulin response is reduced. It doesn't cause diabetes in all women, but the behavior of our blood sugar is similar to pre-diabetes because of menopause. We see changes in our cholesterol with rises in our LDL, which is bad cholesterol, and our triglycerides. And many women will experience weight gain. And if women don't address the change in their menopause, typically women will gain 10 kilograms as a result of menopause only, without having made any dietary change, without having changed their usual exercise, and they will gain 10 kilos. So we know that loss of estrogen increases the risk of heart disease by 4 times what it was prior to menopause. This is particularly relevant to women who undergo premature menopause, and women under 40 whose estrogen has fallen are absolutely recommended to use HRT. But the advice that's been given to women over the decades has been incredibly confusing and conflicting. So up until this year, women with heart disease or women who'd had a previous stroke or had very high blood pressure were being recommended to stop their HRT or advised not to start it. And expert groups had been advising doctors that HRT might increase the risks of cardiovascular disease. In parallel to that, women who have heart disease and high blood pressure are more likely to experience more severe hot flushes and sweats during menopause. And the advice was contradicting. So healthy women were being told that taking HRT would actually protect their heart and protect their blood vessels. But once women had a diagnosis of heart disease, they were then told to stop HRT and to avoid it. And the big question was why. So any of the doctors involved in menopause care, like myself, would be immediately challenging that, saying, that's not making sense. Why are we advising healthy women that using estrogen is going to protect their blood vessels, and then telling women who have heart disease that they need to stop it? The previous studies were all based on HRT that involved tablet-based estrogen. And we recognize now that that's where a lot of the conflict came from. The difference between oral estrogen and transdermal estrogen, so that's a patch or a gel or a spray gel, is enormously important. Whenever we swallow something and digest it, it has to pass through our liver to be metabolized and enter our bloodstream. And that's where the potential for forming clots can happen, because the clotting factors in our body are formed in our liver. So estrogen, which is swallowed in a tablet, going through the liver stimulates increased clotting factors, which is why women taking oral estrogen have a higher risk of blood clot. If you use a spray estrogen, a gel, or a patch, the estrogen is going directly into your bloodstream. So there is no change in your risk of blood clot. A lot of the previous studies that were done were over too short a time period, 12 or 24 months. And so they were inadequate in demonstrating long-term outcomes and protective effects of estrogen for women with heart attacks or strokes. And the majority of the research was predominantly focused on men. So the data for women was of very poor quality and the studies were underpowered. Women were advised that if they improved their, I'm just reading this. if they improved their lifestyle, that their menopause symptoms would disappear and that they didn't need HRT, which is patently not true. I'd love to tell someone that if they take lots of exercise, they will get less hot flushes and night sweats, but there is absolutely no evidence to support that statement. So taking exercise is good for our heart health, but it doesn't help those menopause symptoms that are so devastating, like night sweats and hot flushes. So what has changed? What we have now is some better quality data, and reviews of previous data have been looked at with a modern perspective, recognizing that transdermal estrogen HRT has a very different behavior to oral tablet-based estrogen. When we look at the Cochrane database, that's an enormous research institute that does a lot of reviews on all of the international studies. They suggested that HRT started before the age of 60 or within 10 years of the beginning of menopause is associated with a reduction in development of cholesterol deposits in our arteries, coronary heart disease, and death from cardiovascular causes, as well as all-cause mortality. That same Cochrane database analysed the long-term follow-up of the Women's Health Initiative study, which was the big American study launched in 2001 that created so much controversy. And when they did the long-term follow-up, they showed that there was no increase in cardiovascular events, and that cardiovascular mortality or all-cause mortality in women on HRT more than 10 years after menopause was the only area that caused a problem. So that the women in that study who were over 60, and some of them over 65, given tablet-based estrogen, developed events and complications. Some of them had heart attacks or strokes. But no one in a modern world would suggest that someone over 65 be started on HRT in a tablet form. So that study had drawn the wrong conclusions from the research that they had done. And Cochrane database is satisfied that the evidence supports the safety. If we move to the next slide. We have a new edition of the menopause guideline from the NICE Institute in the UK this year, who've always been incredibly conservative and actually draw on the Cochrane database for a lot of their information. And finally, they've reviewed cardiovascular disease and concluded that estrogen in transdermal forms is safe for women with heart disease, high blood pressure, and previous stroke. So when they reviewed the evidence, the committee noted that in people who have a history of cardiovascular disease, taking either combined HRT or estrogen only, the evidence does not suggest any difference in coronary heart disease risk and cardiac event composite scores in comparison to women who were not using HRT. The committee discussed the evidence and agreed that there did not appear to be any increase in mortality in women taking either combined HRT or estrogen only in comparison to no HRT at all. And they therefore felt that there was sufficient evidence for that HRT did not increase mortality, in which case it's deemed to be safe. If we move to the next slide. In conjunction with that, the British Menopause Society in the UK, who've always supported the use of HRT as a protective mechanism for heart disease, brought out a document this year on guidance for doctors providing HRT to women who've had a previous heart attack. And they've said very clearly that they do not have to discontinue their HRT. If they were using HRT and have a heart attack, they can choose to continue it. The starting dose, if someone had a heart attack last year and then was developing more bothersome menopause symptoms and wished to start HRT, the dose that's required would be gradually increased from a very, very low dose, slowly up to a maintenance dose, which would be a very moderate dose, but not a high dose. The type of progesterone may be important because we now know that the progesterone aspect of the HRT has a relevance to blood clots and cardiac events. So that's further increasing the evidence that the natural progestogens, which are non-androgenic, are the preferred type. And the two that are available as micronized progesterones in Ireland are utrogestin and dufastin. The route of administration of the estrogen is important, and the recommendation is that it's non-oral. That means anything absorbed through the skin or the vagina. So using a patch, using a gel, using a spray gel, and using vaginal estrogen pessaries are considered to cause no increased risk of blood clot. For some women, they will be using cholesterol-lowering drugs as well. And the suggestion is that there's a beneficial, what's known as synergistic effect of using a statin, cholesterol-lowering drug, in conjunction with estrogen. So you get a better effect on your cholesterol if you're using both. But the recommendation from the British Menopause Society is that because this situation is slightly more complex than someone going through menopause who's never had a heart attack, that it would be wise to have supervision from a doctor who has a specialist qualification in menopause care. Does the progesterone matter? Let's look at that in more detail. We know that there's insufficient evidence to date on blood clot and cardiovascular disease related to progesterone, because in a lot of the previous studies, it wasn't recorded exactly which progesterone ingredient was used. It just said combined HRT or estrogen only. So that we don't have really good quality evidence on the risk related to combined HRT versus estrogen only. And some of the evidence suggests that there are qualities in some progesterones, like the new one, drospirenone, that can have a positive effect on cholesterol lowering. So that's really important. There are studies planned at the moment and some beginning in different countries internationally to really take a detailed look at the effect on cholesterols and heart disease in women using different types of progesterone in their HRT. And at present, in women who have a heart disease diagnosis or previous stroke or high blood pressure, we are prescribing the micronized progesterones, utrogestin and dydrogesterone. And what's good news about those two progesterones is that they have higher breast safety ratings as well. So overall, they're much better quality progesterones. And we'll look at the next one. So when we look at stroke in particular, there was detailed guidance on stroke in the new menopause NICE guidelines. That's due to be published formally in November next month. But looking at the evidence, the committee concluded that combined HRT in stroke was important if women were aged over 60. So that using HRT up until prior to the age, starting it before 60, made no difference to outcome from stroke, except in women who were over 60 when they started their HRT. So when we're counselling women now, if they had a stroke at 51, and at that point we're not on HRT, and at 62 attended me and said, I'd like to start HRT, even with transdermal, I would have some concerns that there is a risk because the behavior of our blood vessels for stroke is different to heart attacks. What came through in the evidence on stroke was that there's also a relevance to a woman's ethnicity, because women with Black ethnicity developed higher risks for stroke and had more risk related to HRT if they'd had a previous stroke. So the committee felt that they could say that using transdermal estrogen was unlikely to increase the risk of stroke, but supporting women with HRT with a previous stroke needed to be done very carefully. We have a guidance document from the Thrombosis Ireland group, giving women information about menopause when they've had a blood clot in the past. And this has been very helpful. It's the same booklet that was produced by Thrombosis UK, and it was published for Thrombosis Ireland with permission. It's interesting to note that the chief author on that booklet was Dr. Louise Newsom, who's been talked about quite a lot in the news media recently. But the document is a very, very robust one. And I've just added that sentence from the booklet because I really love the clarity of it. And it literally says, to be clear, transdermal estrogen has no extra risk and is safe to take, even for those who have a higher risk of getting a blood clot. So this leaflet has been really helpful in building confidence, and particularly because a lot of women, when they had a clot in their lung or had a previous stroke, were warned specifically that they should never use hormones. And so when they reached menopause, they just presumed that they could not have HRT. And trying to counsel women who've been given that guidance by a consultant takes time to explain that actually that advice is now out of date, and that the current evidence would suggest that it's very safe for them to use HRT, and that using a patch should not increase their risk of another blood clot at all. But the leaflet has been very helpful. And we'll take the next slide. So what are the European Society of Cardiology saying in 2024? And I had a little look. They've published a new guideline on hypertension just at the end of August, beginning of September, which is really, really useful in medical practice. And it's going to be tough because they've introduced much lower blood pressure targets for us to achieve in any of our patients who have high blood pressure. So we have work to do. They've also introduced a new category of blood pressure, which is in between normal and hypertension. We've got elevated blood pressure. So that, I think, would be people that have previously been told, oh, your blood pressure is borderline. That's now considered elevated blood pressure. And a bit like pre-diabetes, it requires specific timetable screening to monitor, because we know there's such a substantial risk that over time the blood pressure will then become higher again and require medication. The emphasis on blood pressure in the new guideline is suggesting that achieving good blood pressure control is really key in protecting people's hearts. So we have to work really, really hard with blood pressure if we want to protect your heart. And the other thing that came out in the annual conference from the European Society of Cardiology was the substantial benefit that had been achieved in heart health from people taking semaglutide. And quite a few women who've undergone a rapid increase in their body mass index around menopause will often ask about semaglutide. And we're really happy that it's a very safe drug for them to consider. So that it was very good news to hear such a robust endorsement from the European Society of Cardiology. And it was quite interesting that they'd been following through all of their cardiac patients who coincidentally had been prescribed semaglutide either for diabetes or from their endocrinologist because they had a high BMI, and they had achieved a huge amount of benefit from their heart health. So that's an interesting one to think of. But it's also important to note that the European Society have acknowledged that women remain underdiagnosed of heart conditions, and they've advised clinicians to record female-specific risk factors. And those are things like polycystic ovarian syndrome, gestational diabetes, preeclampsia in pregnancy, and premature ovarian insufficiency. And in parallel to that, the European Society of Cardiology have also acknowledged that the current risk scoring systems do not honestly reflect these female-specific risk factors. So that really when a doctor is talking to a woman about her risk of heart disease, you do the risk score and then add to that the female-specific risk factors, because the risk score doesn't really include them. However, All of that aside, the European Society of Cardiology have still continued their recommendation that women avoid HRT if they have a diagnosis of heart disease. So we have a bit of work to do to bring the European Society of Cardiology on board. In the next slide, I just have a little table to demonstrate the importance of those reproductive conditions and to demonstrate how much it affects our risk of heart disease. So this comes from a study by Stunkel that was published in Climacteric in January 2024, but the original study was OCOF. But in this table, you can see that women who suffered from preeclampsia, stillbirth, or premature labor have a twofold increase in their risk of heart disease. Women who had high blood pressure in pregnancy, placental abruption, premature ovarian insufficiency, or diabetes in pregnancy have a 1.5 to almost 2 times increased risk of heart disease. And the women who had a very, very early menarche, that's the beginning of their period, so maybe they were 8 when their period started, if they had polycystic ovarian syndrome or early menopause, had 1.5 times increased risk. Whereas the one thing that's really useful to see there is women that breastfed for longer periods of time protected their heart. And that's something I don't think that's necessarily published an awful lot, that breastfeeding protects our hearts. But it's a lovely piece of information. So breastfeeding for longer periods of time protects your heart. Now, it's fantastic. And we have a whole network of complex menopause clinics throughout Ireland now. So any of those women who need to come to a complex clinic should just ask their GP to make a referral. We're delighted to take these referrals. And as I say, there's a network throughout the country. So help is available.